behalf of the Sri Lanka College of Internal Medicine, I would like to warmly welcome you all to this webinar. Now, in our audience, we have a gathering of consultants, consultant physicians, anesthetists, intensivists, family physicians, and other consultants. Today we are going to hear Dr. Mahendra Ekanayaka describe his, share his experience of handling COVID patients. He has been working at the Homagama-based hospital for over a year now. So he has gained a wealth of experience seeing and treating those patients. And it's a timely topic because we know that in this third wave, we are seeing a large number of cases. And more than that, we are seeing a large percentage of ill patients. And patients needing oxygen is close to about 20%. So that is a very high percentage, and that has made this a very challenging task. And I'm sure we all appreciate the fact that COVID-19, severe COVID-19 is a complex disease. No two patients are alike. It's quite heterogeneous, so the demands of each patient is different. So I think we really need to have a dialogue among us, and I think this is an ideal opportunity to initiate that dialogue. And I think this would be in the form of an interactive discussion, but Dr. Mahendra would like to share his experience with us at first. And then what we would do is we would leave time for discussion. Feel free to raise your hand and indicate that you would like to ask questions. And we would have a dialogue, because I think it's only through an honest dialogue among consultants that we can improve ourselves and manage these patients better. Now, over to you, Mahendra, to start your presentation. Thank you.
Yeah. Thank you very much, Dr. Harishchandra, for inviting me to deliver this. Actually, it's not a talk, it's just an informal, probably a discussion of what I have seen over the past 1 year in seeing these patients, because I was fortunate enough to see two ends of the same disease at the same time. I am working at BH Homagama, as you know, it's a tertiary level care hospital. At the same time, I was fortunate enough to work at the District Hospital Vathara as well, which is a level 1-2 type of care hospital. So I have seen the journey of a patient from home to the ICU within few days. So, so my talk will be based on, most of the time based on evidence-based, plus some of the videos and some of the ideas that I'm going to talk to you today is based on the working experience. And of course, I have discussed this with very many senior colleagues of in my hospital. I was fortunate enough to have the 3 senior colleagues in the likes of Dr. Narangoda and two others, plus I'm always getting advice from the IDH senior consultants, Dr. Vijay Vikram and Damayanti and all. So I was fortunate enough to learn my basics because I'm always thankful to those my senior colleagues, and just I'm showing what I have seen during past few weeks. So this, as I said, this is a sharing experience. I'm going to take you through few entities and first of all, I would like to say that this is only a fact-finding mission. There's no hard feelings, we are not going to find faults with someone else, faults with anyone's management, just sharing what we are seeing. And secondly, I would like to talk to you all regarding whether we could decode the mystery of dying due to COVID-19, especially when the cases are rising and we see patients are dying more and more in the wards. And next is, are we in the brink of the tsunami of the walking dead? So this was a phenomena which was phrased 1 or 2 years back in US, and I firmly believe that we are seeing we are going into that uh, we are in the verge of getting into that sort of a tsunami if we don't act uh, promptly. And this is again going to provide a closer look at the patients. Some of you all may not have seen closer patients with very close proximity. So I can show you some videos of patients seeing, and I firmly believe that seeing and knowing is believing, and it's up to you to decide. Uh, and finally, this mission is not to admit any impediments to the greater services we are doing in Sri Lanka as a team, as a medical fraternity. One patient or a case to us is a whole world to a child, wife, husband, mother, father, brother, sister, or a friend. Just place yourself in a HDU bed down with COVID-19 for a moment, and then you will realize the gravity of it. So today's outline would be, I'm going, because after the new year, we were happy, and after the new year, I mean, our, has the game changed actually? But with the recent reports, yes, we have to agree the game has already changed, even without our knowledge. And I will talk to you on COVID speed, COVID with subclinical pneumonia with evidence of exertional desaturation, the earliest form of COVID pneumonia that one can identify. It's a novel entity. And then the silent hypoxia and early detection, how we can detect silent hypoxia early, and what is silent hypoxia, and safe transfer of patients, giving oxygen at small hospitals, what are the basics of giving oxygen, just few lines on that. And to and we are seeing more and more patients even within the first week of illness getting steroid prescriptions at various levels of treatment facilities, and whether we can avoid steroid misuse, that's the need of the hour. And proposed triple therapy and triple measures if to combat this issue. And we are seeing increasing number of bad COVID pneumonias, especially 30 to 60 age group, especially after the new year. Some do not have any significant risk factors. And I can give you many examples just to outline few. Young pregnant lady whose saturation dropped suddenly to 70% postpartum. 35-year-old female with PV bleeding, COVID positive, transferring for a blood transfusion with normal saturation levels. And again, a 44-year-old female with chest pain, diagnosed with NSTEMI, transferring for a further management of NSTEMI with normal saturation. So the list is too many. So we will try to see some of these patients. This is what the Reuters has to say. You can see the daily new infections and the daily deaths. So it's nearly over 40 these days. A bit of Sri Lankan ministry guidelines, the latest guidelines on May 25th. Classification, moderate disease, low saturation less than 94 on room air, and severe disease, as you all, I think everybody is very much familiar with these classifications, just to recollect thoughts. And according to the current guideline, Sri Lankan guideline, the most recent, the criteria to start to treatment, oxygen therapy, steroids, especially they say moderate to severe group. That is the group where they need oxygen and they show desaturation that is less than 94%. So I'll take you all through some of real patient case scenarios. So this is a 35-year-old male patient admitted to base hospital Homagama on 17th April. PCR was done on 14th. Has had a fever, shortness of breath, and cough for 4 days. SpO2 on arrival, it was 94% with 6 liters of oxygen, and patient was dyspneic on exertion. Is this patient considered out of danger? There is a question. And this was the chest X-ray which was taken on 19th of April. Easily, when you ask to Viber this picture, this can easily go unnoticed. You know, if the radiologists are joining, they can probably see some changes, but obviously for a medical officer, house officer, this may look normal. Can misinterpret seriousness, but of course it's a valuable asset in a resource poor setting like ours. But this is the HRCT which was taken 1 day before the chest X-ray. This was taken on 18th of April, and virtually there's no lung tissue at all. And if you can have a closer look, now see the date, it's 18th. The chest X-ray date was 19th. I'll leave that part to you to think. And first PCR date on 14th April, fever for 4 days to recollect everything, accepted on 17th, admission SPO 84 on NEA, but it's increased to 92 with 8 liters of oxygen. 18th ICU, high flow, CPAP, intubated, ventilated, expired on 22nd. Very rapid deterioration, and the father of 2 or something. So this brings us to a entity, you know, just to recollect some of the basic knowledge on saturation. Saturation, SpO2 and PaO2 are 2 different things. And what do you mean by saturation of less than 94? So these are the things that we would want to see. Saturation at rest versus saturation after exertion. Now, usually in the wards, we do check the saturation. Sometimes the patient are walking, sometimes the patients are after going to the bathroom, they are coming to get the saturation checked, or sometimes the patients are lying down on beds. So we are checking saturation in it after different levels of exertion. And when you are using the pulse oximeter, my senior colleagues of anesthesia and intensivists would agree, because I myself was an anesthetist for a long time before taking up this job. So pulse oximeter display, there are values, trends, graphs, even the sound, it dies out when the saturation drops. Sometimes, you know, you can tell the patient's saturation is dropping from a distance. And the waveforms, signal strength, indicators, all are important. You know, you have to open up, you have to look closely, and I mean, so saturation, these monitors are a wonderful piece of equipment. If you know the equipment, you can do wonders with it. Again, next thing, saturation 96. Is it normal? Now, when we do a ward round, usually the junior doctors will say this patient so and so saturation 96. And what does that mean? Patient who is resting in bed or chair, it may be different. Patient after exertion, After initial lag of 20 to 30 seconds, saturation 96 may be different, and patient may be on 10 liters of oxygen or via NRBM or high flow and still can have 96 saturation. But this problem, we didn't have this problem before we are facing COVID. But as you know, in almost everywhere, not even in Sri Lanka, in other countries also, the contact and going closer to the patient is difficult most of the time. Other than the serious and bad patients in the ICUs and HDUs, in the normal ICCs and wards and all, you tend to check the saturation and tend to take the record the observations from another side of a glass pane. And virtually you are doing it from a distance. And we need to emphasize the value of resting saturation versus post-exertional saturation. Is quite similar to the blood pressure. Sometimes the blood pressure, think of why we are doing the ambulatory blood pressure. One indication would be to detect the reverse of white coat hypertension, reverse of white coat hypertension. And same here, saturation is totally depend on oxygen supply and the demand, or the oxygenation versus oxygen use up, lung end versus the tissue end. So there can be a lot of variations in between those two ends. And one single most important factor which utilizes oxygen is the metabolic rate and the activity level and the exertion, degree of exertion. And again, SPO, saturation with oxygen versus saturation without oxygen. Are we conscious enough to look into the value and ask whether the patient, when somebody says saturation 90s, are we conscious enough to ask whether the patient is on oxygen or not? Because you don't see them quite often, when you are looking. I mean, if you can visualize a usual ICC setup. I'm not talking about ICC intensive care, so HDU settings, but in 100 patient dormitories or ICCs, small hospitals. Sometimes, patient has to walk up to the pulse oximeter to get the saturation checked. And sometimes, they come without the oxygen. Right. We'll move on to the next stage. Is life possible with saturations below 70? Yes, it is possible. Now, if you think of the acclimatization with Mount Everest climbers, there are recorded saturations of 50s, 60s, but they still can, but they are acclimatizing. But what if the saturation drops below 70 to 60s, 50s within minutes or within seconds? I mean, within minutes or within, within very short period of time? Can the body physiology adapt like in mountain climbers? This article, I mean, this is quite, when I first read this, I too got a little bit annoyed as a physician. And this was published in Critical Care Perspective nearly 1 year ago. COVID-19 silent hypoxemia is baffling to physicians. And I'll read out few lines. And it says, patients with coronavirus disease are described as exhibiting oxygen levels incompatible with life without dyspnea. Some patients. The pairing dubbed happy hypoxia, but more precisely termed silent hypoxemia, is especially bewildering to physicians and is considered as defying basic biology. We can recall that, in usual before COVID, when you in an usual ward round, we tend to check saturations when the patients are showing signs of increased work of breathing. And we would never expect patient saturation to be 70 and the patient is seated talking on the phone and looking at us. We have never seen that. Yes, we are seeing it now. And again, another few lines, it says, without knowledge of these mechanisms, physicians caring for patients with hypoxemia free of dyspnea, are operating in the dark, placing vulnerable patients with COVID-19 at considerable risk. This is not my views, this is what the critical care perspective has to say. This was published in initial stages of, in I think in US. That's what they observed. And now, without talking too much, we'll go on to see this video, and I would say that I must say that these patients have given their fullest consent and cooperation in recording and sharing these videos for the betterment of the medical, for the upgraded knowledge and treatment purposes. So just observe these patients and think. Sorry, see what we can see. You can see a 83-year-old female. Just observe what you can gather. Just concentrate on the increased work of breathing and the monitor. Is this possible? Now, when you see a saturation of 82 on a normal looking patient, not dyspneic, no increase of work of breathing at all, usual thing is, first thing is we tend to think that probably the monitor is wrong, or probably the nail polish or something, or maybe nail problems. But patient doesn't look that cyanotic as well, to this degree of saturation of 82. I'll take you through the course of this patient in a few minutes. Now, this was the observation chart. Initially, doctor admitted, recorded low saturation. He put the patient on oxygen 97. Subsequently, since the patient looks normal, and others thought that probably the machine is wrong, or maybe patient can have normal saturation of 80, and since the patient is not dyspneic or anything, and they took off oxygen. The next day it dropped to 67, and by this time patient showed a little bit of signs of increased work of breathing. We'll talk about the window period. There's a grace period where the God has given us to act. Time between the drop of saturation and the time taken to display or show signs of increased work of breathing. So we'll discuss a little bit more on that window period later. So it has dropped to 67, and again started oxygen. This was the arterial blood gas we did on the same time. As you can appreciate, saturation is 78.9. It's quite comparable with the pulse oximeter saturation of 80, and PaO2 of 41.3, and there's no much of type 2 respiratory failure, and importantly lactate is 1, and there's no much of acid base imbalance. pH is 7.343. And this was a chest x-ray which was taken those days. Just signs of COVID pneumonia. And the patient journey, then patient, and I have a beautiful team in BHH, ICU, HDUs, and the nursing and the other staff. And this patient was managed beautifully in the ICU for nearly 17 days with only escalation of oxygen treatment. I think highest oxygen requirement was high flow oxygen, and she never went into CPAP. I can't, probably maybe, but not ventilated, not given TOSI, just given steroids, enoxaparin, antibiotics, and the hematologist, the microbiologist, 2 consultant anesthetists, and my other 3 colleagues, we all have seen this patient. And after 17 days, patient recovered, and 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 patient went, and further patient stayed another 2 weeks or so in the ward. And after 44 days, we discharged this patient, and I got down this patient 2 weeks after this discharge, and see the state of the patient. So if you listen carefully, when you ask what was her initial problem, she only says that mata kanda beruwa thamai hitiye. She doesn't even know that whether she had a low saturation of 67 at some point. And we did the post-exertional desaturation test, and it never dropped below 95 at this point. So saturation of 67 after 44 days increased up to 97. And this is, so to start with, this is a success story. And we have, my colleagues will, who are treating COVID will all agree, everybody has experience. I'm just showing some videos to you. That's the only difference between me and them. Mm, right. So the next thing would be now how to classify. There are different, very many ways of classifying COVID patients, COVID pneumonias, but we need to give a working diagnosis for the house officers and the medical officers who are who are doing a greater job in the wards in the day and night with risking their lives. So, uh, is there a way to decode the mystery of dying? Is it possible till we find that wonder drug or intervention, or till we find that magical wand where we prescribe this and the next day patients are cured, like kind of thing? And I'm waiting till that day comes. And again, the direct effect of pneumonia and hypoxia, it, it is well established, and we will talk a little more on collateral damage of COVID. Somebody can write a good article on this. And collateral entities would be, once the patient becomes COVID positive, the 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 things that the patient has to undergo. So either their saturation will suddenly drop while in HDUs, ICUs, or in wards, needing escalation of treatment. So when you hear somebody saying that all of a sudden patient was saturation was maintaining on NRBM or in high flow of about 90, 94, all of a sudden patient saturation dropped to 60 and patient developed severe breathlessness, you know, usually your go-to diagnosis is whether it could be a pulmonary embolism. That is something to think. And sometimes, these patients are ending up, quite correctly, will end up escalation of treatment, maybe in the forms of CPAP or intubations. Sometimes, collateral damage can comes in the form of myocardial infarctions. We will see some evidence. Sometimes other general conditions like PV bleeding and severe anemia, strokes, surgical issues, renal failures, even comes as accidents. And this patient was 35-year-old female, fever 2 days, and transferred to us with severe anemia. She had undiagnosed menstrual bleeding and anemia. Her saturation from the transferring center was 98 on air, so COVID positive for transferred for a blood transfusion and further investigation and management of anemia, and was, quite correctly, probably not correctly, given tranexamic acid. No, no issues with that. Uh, and this was the saturation, observation chart when we first saw this patient from our end. There was a saturation of 96 recorded in this young female. Is it normal? Is this normal for a young 35 without lung diseases, without, my anesthesia colleagues will appreciate, if the saturation drops to from 100 to 96 while patient is under. So that's a panicky situation. Actually, we get a little agitated. Or so when you see a saturation of 96 on a young normal female without any history of lung disease, can you just ignore this figure? So the next day, the saturation is 97 without oxygen. And we'll see the progression of this patient. So obviously, this patient cannot undergo any exertional desaturation tests. But what we did was, usually these patients are mobile. They walk several times up and down in the wards to go to the toilet, to grab the food, to come for the monitoring station to get their saturation and the observation checked. So we correctly timed checking the pulse oximetry. So we took the saturation after walking up to the pulse oximetry. It was 91%. And after 1 minute rest, it reversed back to 96. So, so is this phenomena is possible in a normal young patient? Could be. Somebody can say that, anemia may be causing low saturation, but physiology says something else. And this was a chest X-ray again. Yes, early signs of COVID pneumonia. And I'll show you the same day CT, HRCT. I'm quite privileged to have the CT scanner and a quite beautiful, wonderful team of radiology department with me at BHH. So without their effort, nothing could have been possible. Would have been possible rather. So this was a CT scan of that patient when the saturation was 96. So you can appreciate all these changes of COVID. So, and this is my radiologist for you. And HRC represents are in favor of typical changes of COVID pneumonia. And we immediately started triple therapy. And this was because as I said, beautiful team, dedicated hematologists, and everybody. So all the state of the art like management is going on. So patient, and after a few days, patient saturation was 100, and even without oxygen. And patient was given 2 blood transfusions and went home safely after 10-12 days with a hematology referral. The next case, rather a patient is again 42-year-old lady with NSTEMI transferred to us with a troponin of 132 and with treatment dose of enoxaparin. And yeah, and the patient developed chest pain on post PCR day 12. So that is a little bit of concern. We tend to discharge them sometimes, even if when they showed no signs at day 10. But this patient developed chest pain on day 12. And this was the saturation when she first came in. Again, saturation of 95 on air. The next day it was 97 without oxygen. So, and the other day it was 99. What is this? Why these different figures on different days? Or is it just the is it just the usual thing of COVID pneumonia, or can we correlate this to the degree of exertion? So we will see later how this happens. And now this patient, 95, we can't do any desaturation tests or anything. So we got a CT scan done, and this was a CT scan of that patient, HRCT. And you can appreciate this. This is all lung fields, bilaterals. All COVID changes with going into organizing pneumonia pattern. But again, this was a chest X-ray, probably the same day or day before. This is a chart CT reporting. Now this brings us to we'll talk little bit more very basic physiology of NSTEMI. Usually when there is a hypoperfuse segment in a precarious balance, maintaining the saturation and function with 90 to 100% with 98 to 100% of oxygen saturation. So there's a imbalance between the oxygen supply and the oxygen demand to that hypoperfuse segment. And oxygen supply in COVID can get hampered due to very many reasons. I've written down very few. You can find very many other reasons. You can fill up the list. But arterial oxygen content is one factor, and the coronary artery blood flow is the other factor. So, what are the factors which impedes the arterial oxygen content? Probably the inflammation and cytokine storm, and very many physiological theories that have come up. Saturation, partial pressure of oxygen, and oxygen content at the tissue level. So there could be a combination of very many things. And also the coronary artery blood flow. When there's already vulnerable segment with a stenosis on a precarious balance, with increasing thrombosis and further blocking, say for example, 80% block patient maintaining the saturation, maintaining the functions with normal saturations, and all of a sudden saturation drops to 70. What will happen to that hypoperfuse segment? Or again, when there's a novel thrombosis, that is also a very well established theory, and thrombosis plus desaturation. And also from the other end, there's increase. What will happen if the oxygen demand increases due to now any cause which increases the heart rate and depth, which increases the cardiac output, and usual day-to-day activities like walking, climbing, dancing, jogging like activities, fever, drugs, nebulizations, probably with salbutamol, increases the heart rate and all, without evidence of bronchospasms. Sometimes when we see a patient saturation dropping, first go to measure would be to give a nebulization and see, even without auscultating. And agitation, stress, fear, all this contributes. And final outcome, there's an imbalance between the oxygen supply and demand for that hypoperfuse segment. And it is very well established that COVID pneumonia is considered a hypermetabolic state. There are very many research papers on this. And any exertion at this point is not good. It's detrimental for the survival of these patients. Yeah. The next. So this is again a very beautiful, beautiful schematic a diagram of continuum of COVID pneumonia patients based on the saturation monitoring. This was published in Medscape almost 1 year ago under the heading of Pulse Oximeter, the Game Changer. It's there in Medscape. You can refer it up. So they divide patients into 3 categories according to the degree of desaturation and degree of clinical signs. Red zone, detection zone or blue zone, and subclinical zone. These are all COVID pneumonias. And they categorize these patients into two parts. Big yield, low resource needed end, and a big yield, low resource needed end, and a less yield, big resource needed end. And at this red zone, you need intubation, ventilation, sedatives, pressors, pumps, ECMOs, and everything. And all the other theories comes in. And they say that their mortality is very high at this end. Versus there's a subclinical zone. We'll go into detail on further whether we can drag this detection zone a little earlier with early detection of speed. But they say that this whole idea of classification like this is depending on the saturation and the degree of work of breathing. So again, it is well established that COVID asymptomatic patients can harbor COVID pneumonias, and some group they have subjective shortness of breath, categorized under subclinical zone. There are another group which they are still subclinical. Their saturation is normal at rest, but they desaturate on mild to moderate exertion. their saturation drops below 94, 95. So that is what we are trying to establish a link between that and the COVID speed, subclinical pneumonia with evidence of exertional desaturation, somewhere in this range, right? And the detection zone where this is very well known entity, silent hypoxia. So to categorize under blue zone, the patient needs to be hypoxic. That is, their saturation needs to be less than 95 to start with, and they have to be silent and happy. So meaning they will not show overt signs of increased work of breathing or at least early signs of ARDS. But once after a certain window period, we can't reclassify that period precisely because PCR dating is quite ambiguous. PCR date doesn't always correlate with the degree of state of the COVID infection, the time period. Sometimes it can get it may you may get a PCR test early, or sometimes maybe in the late stages of the disease. But after a certain window period, for very many factors, the patient will go into. Sometimes the window period is very short. Some patients it's quite long. As I showed you in that old lady, 83 with saturation 77, her window period was quite long, and one in single most factor because she had diabetes and some other medical issues as well, quite old, but her activity level was very minimal. She was doing very basic things in the ward, and she was moving around very slowly, and she exactly adapted to the absolute bed rest type of kind of measures. So she never, went into overt ARDS, but later she went there a bit. But again, some patients with hypoxia, with very many, sometimes patients with saturation of 90 can develop ARDS. Sometimes patients of saturation 70s can develop ARDS. So that varies. But when the patient shows signs of increased work of breathing or ARDS, they are in the red zone and needing. You cannot manage with usual nasal prongs or face masks. You may need an RBM, high flow nasal cannula, CPAP, intubation and ventilation, and ECMOs and all. So that is in the red zone, right? So this is how they classify this word, this preface, this entity in that article. I'll read it out to you. If we move the whole window of treatment from red zone into the blue zone, there will be a logarithmic collapse of the resources needed to fight this disease. There is no win fighting in the red zone. You can't ramp it up enough. The mortality in the red zone is more than 70%. This is in the US data with ECMOs and all the state-of-the-art ICU facilities. Even their mortality is more than 70%, they say. So in a country like ours, what would be the outcome if we wait till the patient go into red zone and start escalating the treatment? So it's quite important to detect them quite early, at least in the detection zone, or if possible, in the subclinical zone where they show the early exertional desaturation. So towards the end of this lecture, my good colleagues, I mean, two colleagues will, if time permits, then they also can share their experience. And I'm quite, I want to mention one name, if at all. I mean, sorry, so we'll move on to the other one. So again, the reclassify these things. So there's a continuum of hypoxia and COVID pneumonia patients according to that classification. I told you there are many other classifications. Yes, subclinical zones, no desaturation, SpO 90 to 100, but they can have subjective shortness of breath. Detection zone, hypoxia with desaturation less than 95, but there's no overt signs of ARDS. And the red zone where it's desaturation plus ARDS. And the patients walk from this end to the other end. That window period is the period where the time taken to develop ARDS. Maybe too short, maybe too long. And longer the period, we have enough time to intervene, and the outcome is almost favorable. Again, the reclassifying subclinical zone, we will try to see, we are trying to reclassify and reclassify few patients, take few patients out of the subclinical zone and put them back in the detection zone called COVID speed, again, subclinical pneumonia with early exertional desaturation. A little bit more on the window period. Now, I don't know, I'm not sure whether you all can see this, but anyway, uh, what is this? Okay. So window period depends on very many factors. Uh, so just give me a second. There's something has happened. Oh, okay. Yeah. Right. So so length varies depending on very many factors. Could be due to timing of PCR testing, and if according to the observations made, if somebody wants to pinpoint one factor, one single most important relevant factor, it is the degree of exertion. So saturation maintaining on 90, 96, all of a sudden desaturate to 70 after going and coming from the bathroom. So with that degree of mild exertion, they can degenerate into severe ARDS within minutes. So my colleagues who are seeing these patients on day-to-day basis would agree with me. So, and again, of course, that depends on the comorbidities, virulence of strain of the viruses, etc. But out of all these factors, the degree of exertion, if somebody wants to make a change, make an intervention, or do some good service, this is maybe the only readily modifiable factor for preventing patients degenerating into ARDS. Right. So this is again. So what I'm going to talk to you regarding a test called Modified Exertional Desaturation Test, MEDT protocol, or med test protocol. You can call it any name. So just observe this patient. She's again nearly 70-year-old patient, and we are doing the desaturation test on her. So we will see how, just observe whether you can pick anything. Saturation 99 with a good pulse waveform. Always remember when you are recording the pulse, the figure 99, just see whether the waveform is uniform and the signal strength, if available, is uh, uniform. Signal strength is next to the figures. So we're just asking the patient, this saturation is 99, asymptomatic, or there's no over dyspnea, and asking the patient to sit and stand, stand and sit for 8 to 10 times, and to keep the pulse oximeter. Unfortunately, patient remove the pulse oximeter, but just fine. This is a normal test response. Even in a more than 70-year-old patient, it doesn't drop below 98 ISO, I guess. That may be due to very many reasons. So this is quite a normal MED saturation response. Unless you have some sort of a oxygenation issue, your saturation shouldn't drop below 96. Unless you have a lung pathology, your saturation shouldn't drop below 70%, below 96% on a normal ambulating patient breathing normal air. So it doesn't drop below 98, right? So this is again a medical officer who's doing the same test, you know. So it's a young patient. So this is how we'll take few minutes, because if at all, if I want to tell you something at the end of this session, this would be the most important thing. how to execute modified exertional desaturation test protocol. So you ask the patient to put the pulse or the subject to put the pulse meter on and record the uh, baseline saturation when the pulse waveform is stable. And her quite young patient doctor saturation is 99. Sometimes, because patients are coming in various stages to the pulse oximeter. Some patients, as soon as they come, we check the pulse oximeter. While checking the pulse oximeter, other patients are waiting on the queue and they are resting. So according to the way how we check the pulse oximeter as of today, sometimes we may not detect the post exertional desaturation after the initial leg of 20 to 30 to 45 seconds, like initial leg. So we ask the patient to stand and sit for 8 times. This is quite normal level of exertion for a normal looking non-dyspneic patient with a saturation of more than 96, because patient is doing more exertion than this during inside these wards. They are walking several times to the toilet, washing clothes, doing their all daily activities. So it doesn't drop. So this is the normal saturation, and this is just wanted to demonstrate how we are doing the pulse oximetry according to the modified exertional desaturation test protocol. Right, coming back, just observe this video and see if you can pick anything. This is in our HDU. So I'll replay it. Just tell me who is the patient now. Uh, I mean, patient of all our patients, of course, but the case of interest, is it the patients who are seated on the bed, or is it the one who's carrying the, uh, you know, tea jug around the ward? So, right. And this was, so that patient was a 31-year-old lady, and she came to us with fever and few signs of diarrhea or something, needing IV fluid, COVID test positive, and she was walking around distributing milk and everything to the other patients, because all the other patients are like more severely ill than hers. And this was a saturation chart. On day of admission, it was 100% on room air, 100% on ONRIA. Third day, 6 p.m., it has recorded 98, 98. So just for the curiousness of sake, just uh, did the modified exertional desaturation test protocol. To start with, at 12:30, baseline saturation of 99. After desaturation test, it dropped to 95. Is it significant? Can a patient, normal young 30-year-old, 31-year-old patient's saturation drop to 95 while walking, or just with mild exertion? That is serious concern. Does this patient warrants treatment? Does this patient needs closer monitoring, or can we leave this patient alone? We'll see. And this is the desaturation that we did on hers on the same day. Yeah, probably, or maybe. Actually, this was done even after diagnosing. She was distributing tea in the ward without complying to our advice. You can appreciate the cannula is not there in the first video. So this was done even before she was distributing milk in the ward, because that is how they feel. They feel quite normal, and even with the cannula, she was happy to carry on her usual uh, good work in the ward, and it was very essential to us in managing patients during these days. So we asked her to sit and stand for, stand and sit for 8 to 10 times, and see her saturation drops. Started off with 99, and it dropped to 95, and the same manner it will rise back. And please appreciate the pulse oximeter waveform. It is quite stable and uniform. You can say a lot of very many things with this pulse oximeter: rate, rhythm, volume, everything you can say. Motion artifacts, very many things you can appreciate with the pulse oximetry waveform. So, but it takes some time to go back to 99. So it stays at 95 and 96 for a few seconds, and it drops. It doesn't drop immediately after stopping the exertion, but it takes at least 15 to 30 to seconds. There's a lag period, and then it starts dropping. 90. If you start with 98, it drops to 97, 96, 95. Stays with 95, 96 for a few seconds, and slowly it will come back to 98. Is it a concern, you know, for these patients? So, so I'm quite lucky enough to have some investigations in my bag at BHH. So this was a HRCT which was done at that time. There's early signs of COVID pneumonia. We can appreciate, right? And this is the uh, reporting of my radiologist who did this, and without her support, I wouldn't. This wouldn't have been possible. And this is the D dimer level on the same day. Same patient, D dimers of more than 5,000. Of that 31-year-old who was distributing milk all around the ward with mild early exertional desaturation, more than 5,000. Doesn't she warrant treatment at this point? Just because I must say that not every patient with COVID pneumonia will show higher D dimer levels. I don't have any answer for that. Sometimes it's severe COVID pneumonias. Remember the ICU patient, Nivea patient. I think he had quite low D dimer levels, even with the degree of COVID pneumonia. But certainly, this patient's D dimer was more than 5,000. And of course, with close observations and initial management, she recovered, and subsequent saturations were 98, 90, 99, and she and before discharge, exertional desaturation test was negative, and patients went home safely. So this brings us to a famous old school analogy. You know, I mean, you can appreciate what it says. It's all self-explanatory. So one end, more resources are needed. More resources are needed. No infighting at this end. We all know, and we are, you know, quite depressing to see patients at this end always. Need more ICU, more oxygen, more high flow, more TOSI, more ventilators, more ECMO, more staff. Sorry for mistakes, spelling mistakes. Uh, Result: more deaths and more blame and less satisfaction. If you concentrate on this end, but is there a other end for this patient? Is there a window period? Is there a beginning to see where we can put a stop, at least at this point? I know there are very many constraints, very many restrictions. The main restriction would be if we cannot, oh, I shouldn't put it in that way. There is a gap between you and, I mean, the doctor and the patient. That would be a better way of putting it. And these initial stages, less resource end, easy to handle, cost effective way, early detection, SpO2 evaluation by bedside, simple bedside SpO2 evaluation, early triple therapy and triple measures, less steroid misuse, because you are not giving steroid for everybody, each and everybody. Nowadays, it has become a fashion. Whenever a patient becomes test positive, everybody's asking for that magical prescription, and which is we will see the consequences later unless we put and stop and put an end to that sort of management right now. And safe transfer, and we will talk a bit on safe transfer, and in that way we can reserve the beds, HU and ICU beds, for the more needed patients and less burden for the healthcare staff. And this is a schematic diagram of how to do the modified exertional desaturation test protocol. Step 1, pulse oximeter on finger, sit and rest for 1 minute, ensure good waveform, document the baseline SpO2. If no contraindications, stand and sit 8 to 10 times. Observe pulse oximeter continuously for 1 to 2 minutes. This is very important because to detect SpO2 dropped after initial lag period, it takes at least 20 to 30 seconds. You can try it with the patients and the physicians and the people, who who are doing it right now in very many centers. They would agree, and it takes initial few minutes. At least you need to observe. Just putting in when removing it doesn't help at all. This is COVID, and this is different, as our president said, and we have to approach differently. Same old school, same theory, same way, same management protocol, same thing may not help because the disease is different. And I would like to draw your attention to this patient to see, to show you the gravity of a little more further. Just observe this patient. Worthwhile. It is worth waiting few more extra minutes, spending few more extra minutes on this without interrupting. Normal looking patient. We are asking because this desaturation can occur early in the disease, middle phase of the disease, or even after late phase of the disease, even after day 12, like in STEMI patients. I think this patient is this, which we recorded little latter part of the disease, probably the second half. We are asking the patient to sit and stand and sit for 8 to 10 times. I cannot count. At the patient, their own rate. It takes only 20 to 30 seconds to do that. And we ask the patient to sit. So it remains 98, 97 for few seconds. If you appreciate, maybe 10, 20, 30 seconds. Sometimes it might drop, increase up to 98. This is all very physiological. And because with the degree of exertion, your rate and depth and lung compliance increases a bit. But see what happens to the saturation after probably 30 to 20 to 30 seconds. Appreciate the good pulse waveform and the good signal strength on the pulse oximeter. So it's slowly dropping down to 92, and it will come up, right? Right. So it will come up to 98 subsequently, right? So sorry, right. So this is the exercise modified exertional desaturation test for you. And even when the patient doesn't show, these are the patients, probably patients in the subclinical group, or that subclinical group patients can be in any stage of the disease, early disease, middle or late, because the PCR testing date is not within our control. It is called probably the healthcare worker. I mean, you know, when you do the when we get the PCR. So there's not like in dengue. Dengue day one, we know exactly day one the illness is from the beginning of the fever, but not in COVID. PCR day one doesn't correlate with the disease activity at all. So that is that's a big issue when managing COVID patients. Sorry for the interruption. So this was a very well validated test, which was published in, validated in Oxford. This is their, this was there in one of the journals. 3% drop of pulse oximeter reading on exercise is a cause for concern in COVID-19. 1 minute sit to stand test. Patient goes from sit to stand as many times as they can, has been validated. The unvalidated 40-step test, take 40 steps on a flat surface, is in widespread use. Neither should be attempted outside a supervised care setting if oximeter reading is less than 96, they say. So what we did was, we thought that, asking a patient to stand to sit for 1 minute is little too much. So we just brought it down to 8 sit to stands. Patients can do it within 20 to 25 seconds, or you can do it with ask the patient to walk up to the pulse oximeter and then check the saturation from that moment onwards. So you don't need to walk the patient up and down, but patient usually in the IC, because I'm talking about the taking the saturation in ICCs and smaller hospitals where always the patient has one pulse oximeter, 40 to 50 patients in a ward. Patient always have to walk up to the pulse oximeter to get their saturation checked. And so that's why we call it modified exertional desaturation test, with all due respect to the founders of this, or the who published this uh, paper on exercise 1 minute sit to stand test, quite similar to 6 minute walk test that we do in interstitial lung disease and in some certain cardiac diseases. And the modified exertional desaturation test protocol is not done if the resting saturation is below 96, chest pain, if the patient is having chest pain, shortness of breath at rest, physical ailments, patient compliance, observer competency. If none of these things are there, we can proceed with it. So whole idea is to detect saturation in on a group early and treat early. Saturation less than 99% on ambulatory or at rest is for concern. Idea is to diagnose the group of patients who desaturate below 94, either at rest or after mild exertion. They will desaturate more on moderate to severe exertion if they are allowed to walk and do your usual ADS. If you ask the patient to, if the patient is living in a two-story house, patient would how many times that they would walk up and down to get their things done at home. Just think of that. To advocate triple therapy and triple measures if the patient meets criteria according to the national guidelines, which was the most recent guidelines, if they warrant treatment. This whole idea is not to prescribe or treat them everybody with these steroids and everything, at least to detect desaturation group. And when they desaturate, their resting saturation drops below at least 94 without waiting till they develop red signs, to detect, especially in the wards and ICU settings. Increasingly, we are seeing from our end that one usual question that I ask from all the uh, all the colleagues uh, uh, when I take over patients, at least what was the initial state that they came in to their ICC. I mean, so usually they are saturation normals. They are quite asymptomatic, and after 2 3 days, depending on the degree of exertion and degree of certain factors, either with the chest pain or increasing shortness of breath, or increase worsening ARDS, they get their treatment escalated. We are taking over from our end, so that window period is always there, always there. If you look carefully, if you pay some attention and time, you will realize the gravity of it. So a little bit on triple therapy and triple measures. This is nothing new, only for patients with COVID pneumonia with saturation below 94 and show signs of increased work of breathing and in the verge of going into respiratory embarrassment. These three measures, these all measures are very well established. Dexamethasone recovery trial, dose and taste may be, may be different. So this will negate, counteract the inflammation theory, cytokine storm, and maybe very many other factors. Maybe there is an X factor which is contributing to this deterioration. I'm not sure, but still I strongly believe there's maybe a certain other factors which we don't know yet. But certainly inflammation and cytokine storm is very well established, and steroid has proven some benefit for it. Second thing, hypercoagulability and thrombosis, very well established. MIs, strokes, pulmonary embolisms, all reported and all very well established. Subcut enoxaparin, plus or minus aspirin, depending on the treatment protocols, is again everybody is using. And judicious use of IV antibiotics and IV fluids in the form of maybe IV fluids or maybe in the form of ORS. The main idea is not to dehydrate them unless they are in renal failure or unless they are in overt heart failure. Because if you think of the verge of triad and thrombosis theory, sluggish blood flow, increased PCV, like in like in polycythemias, they are more prone to develop thrombosis. So this will all three physiologies, sepsis, hypercoagulability, inflammation will cover with triple therapy. Just a just a simple, easy to remember name given. Because and triple measures are to improve tissue oxygenation and to conserve oxygen which the body already has. Awake cyclical positioning, very proven, with alternate left lateral, right lateral positions every 2 hourly. All this can be very easily done in ICCs and home care or smaller hospital levels. Supplemental oxygen depending on the degree of hypoxia. This is very important. Depending on the degree of hypoxia, not everybody needs high flow, not everybody needs higher oxygens. But one thing, when you are giving, at district hospital where I see some patients there also, and sometimes when they say this early exertional desaturation, what we advocate is intermittent oxygen. You ask the patient to, whenever they want to go to the toilet, we ask the patient to pre-oxygenate them. There's a cylinder beside. We ask the patient to put on the mask, pre-oxygenate for 5 to 10 minutes, and slowly go to the toilet, do their work, and come back. And soon after coming back, again put oxygen for 5 to 10 minutes, and then go for bed rest or to do the positionings. So in that way we were able to save a lot of oxygen. And when the patient saturation drops consistently below 94 only, we put the patients on escalation oxygen treatments, little bit more on oxygen therapy. Now there are, in smaller hospitals, there are two main items that we use: nasal prongs and the face mask. Some hospitals, they do have NRBM, but it uses up quite a lot of oxygen. Yes. One thing, rule of thumb, if you are putting a patient on nasal prongs, please do not put more than 4 to 6 liters of oxygen. Maybe my go-to rate is at least 4 liters maximum. Do not put 6 to 8 to 10 liters, because the jet effect will, the patient can't tolerate, they will get holes in the nose. Sorry for that word. And if a patient the saturation cannot maintain above the desired level with nasal prongs, then initially intermittent, then nasal prongs, then next go to modality would be to go for face mask. One rule of thumb: if you are putting a patient on face mask, don't give aliquots of oxygen while the patient is on a face mask. There's a subconsciously we will put the patient on rebreathing effect. At least start the face mask with above 5 liters of oxygen. Do not put 2 liters, 4 liters on face mask. So because of the rebreathing effect, patient will rebreathe and their saturation will drop. So face mask at least above 5 to 6, and you can go up to 6 to 10, 12 liters max. But If the oxygen requirements goes up beyond that, probably next thing would be to go for NRBM. But again, same theory, do not put 2, 4, 5, 6 liters of oxygen when a patient is on NRBM. At least make sure that the bag is full before putting into the patient. Right, I have seen quite often. I see patients on NRBM, not saturation, not picking up, and the bag is fully collapsed. The NRBM effect is not there, and true and for the junior doctors, first fill up the oxygen, connect the NRBM before putting into the patient. See, because within 1 or 2 minutes the bag will fill up, and then put it into the patient and observe the movements of the bag as the patient breathes in and out. That's the way how forward. So that is, I think, I'm not going into the other areas of oxygen delivery methods. This is what we need to manage a patient at district hospital or ICC setups. Sometimes you may need an NRBM uh, if you want to transfer a patient. And the other thing is, I will talk a little bit. Yeah, so we'll talk about the safe transfer later. So and the other third measure would be to minimal exertion and strict bed rest. This is a must, and everybody would agree. Patients, they such a single most factor. If you want to take home today, patient doesn't degenerate all of a sudden. There are no hidden theories. Always there's a correlation. So there are very many examples which I can show you. One patient maintaining saturation on 96 on NRBM or high flow, wanted to go to the toilet without waiting till the staff comes, dropped it near the collapsed and dropped it in the bathroom. So I mean there are very many reasons. So the walking dead phenomena is not a illusion at all, and we are seeing it more and more, and we will see it more and more. And when a patient is one other observation that I've made is when a patient is with a bystander, where we can provide all the support for all the things inside the ward, their survival is more. And this is quite similar to what we are advocating, in dengue critical period. We are not allowing them to get down from the bed and all. We are providing everything to the wall, and we are giving closer monitoring, and other than the fluids, we may not do anything other than monitoring and allowing them to bed rest. So I think it's high time to come up with a similar sort of plan for at least for these HDU and ICU patients, or patients who are desaturating. So this is again easy to remember. um, uh, Triple treatment and triple measures. Even in the middle of the night, even if I get a call saying patient saturation is 88, what to do? I said, all I have to say is if there are no contraindications, put the patient on triple therapy and triple measures. It makes my life easy. So I'm quite used to this. My house officers knows this. Triple therapy and triple measures are easy to remember, but once the patient right once the patient enters red zone, that is hypoxia with ARDS needing impending ICU care, the management becomes extremely difficult to recollect everything. All of us managing COVID patients should possess at least this much of knowledge within a short period of time to be able to manage influx of patients to general medical settings in near future. Just thought of sharing knowledge. Actually, this slide was made quite little some time ago for a different group. Uh, so this is again one of the areas of debate. I'm just giving my observations. Encourage out of bed to chair or not. So I can give you hundreds of examples on patients. And after this session, if doc, Dr. Krishanta Jayasira can join, he would elaborate it more further on that. And I really appreciate if he and Gayan can share their views on this. 20-year-old primate, 35 weeks POA, emergency section for fetal distress, recovering, S- SPO of maintaining with high flow or something, and was not dystic at rest, suddenly deteriorating, sudden drop of desaturation needing escalation of treatment. So when you get a call saying patient's saturation drops all of a sudden to 70, first go to diagnosis would be in the middle of the night would be to think of a pulmonary embolism and increase uh, thrombolytics rather, maybe. But the main rule of thumb is that in pulmonary, if it has to be a massive pulmonary embolism, and if it is pulmonary embolism, when you put on oxygen, it will not revert back to what is the usual near normal levels. So if it drops below 70 and after putting higher concentration of oxygen, if it comes back to 1988, 100, please rethink your diagnosis. It's sometimes you can correlate it with the degree of exertion. So we have had a lot of accidents. I mean, we have to talk this openly, and there is a big issue caring for these patients. All the wards, minor staff, nurses, doctors, junior doctors, and all the professionals are doing a wonderful job at the moment. Only thing is that we cannot give care for the patients like we did in dengue. We have proven with dengue that we can give that sort of a care, but unfortunately, there's a gap between the healthcare worker and the patient for this unfortunate disease. But still, the patients who got this care, maybe with a bystander, test positive bystander who's accompanying the patient, they survived. They show quicker recovery and use a wheelchair to move around, and not to move around unnecessarily, and only to move around just maybe to get off bare minimum things in the ward. Progress to acute ARDS. I mean, in this kind of scenario, it's more rational to think. Unless you see how saturation drops with your own eyes, you will not believe. The next video will be on that. This is an entity you cannot research by doing a formal randomized control trials. You can't randomize the patients for exercise and not exercise in a ward, do you? So only way is to see, listen, and observe it by yourself. So I was fortunate enough that one of my junior doctors has recorded this, and I'm sharing with all due credit for the junior doctor. He was uh, um, very capable of giving a small narration of what he saw in the video. You can appreciate if you can listen. Just listen to this. The name is a fake name. Just appreciate saturation is dropped to 95 with NRBM. This was recorded with full patient consent. So right. So just imagine you let this patient walk without oxygen up to the toilet and come back without oxygen. So even after soon after removing the oxygen mask while the patient is seated on the bed, it drops to 85. Just imagine going and coming from the bathroom after 10-15 minutes without oxygen. Certainly, yes, it will drop to 60s, 70s, and patient will throw up all the signs of hypoxia-driven myocardial infarctions, hypoxia-driven multi-organ dysfunctions. All the hypermetabolic tissues cannot withstand desaturation for longer periods. So certainly, this is what you call the tsunami of walking dead. So again, with more on window period, actually, does it exist? I want you all to observe closely with your patients. Time taken to develop signs of ARDS in a patient with speed or silent hypoxic patient with COVID pneumonia. Some develop early, some late. Degree of exertion is uniformly observed. Nothing happens out of the blue. There has to be a reason. And if you catch during this window period, there is a hope for survival. And we have to think ways and means of how to do it, how to bridge the gap between the patient and the gap in the sense, the distance between the patient and the healthcare worker. And and this is the article, the Medscape article I'm always referring to. Home pulse oximeter could be the game changer, says ER Dr. Medscape in 2020, April 24. It says, this we read it out. Clinicians need some way to win. He added in the interview, waiting for people to have pulse ox saturations in the 50s and 60s is asking for a tsunami of the walking dead. But the walking dead phenomena is indeed what ER doctors are currently reporting with many COVID patients. And I think we are seeing more and more patients like this. Isn't it the same we do? Isn't the same we see in our wards, the tsunami of the walking dead is yet to come. So learning points to recognize the differences between resting saturation and the post-exertion saturation. Saturation is not a static measurement. Ideally, we should measure ambulatory saturation. In a normal person, it appears static because there is no imbalance between the oxygen supply and the utilization. But in COVID, it's different, very many physiological and very many theories. There is a serious issue of oxygenation process at pulmonary capillary end, and there is a greater utilization and unloading at tissue level as COVID pneumonia is considered a hypermetabolic state. Or is there something we are missing already? Is there a factor X which contributing to all these underlying things? I'm not sure. Simple measures and tools can make a big difference. COVID speed, again, bit more and med test protocol is subclinical pneumonia evidence of post-exertional desaturation, modified exertion research test protocol again. And I can talk to you more and more regarding patients like this for whole day. This is a patient we diagnosed with early exertional desaturation at DH Vathara, and patient next day it drops below 94. Patient was put on triple therapy, but with limited facilities initially, we wanted to get send the patient to a different hospital, and the next day from that hospital again I had to take the patient back to the base hospital Homagama with a saturation of 92 on oxygen. So, but luckily, the patient was with steroids and other measures. Patient survived. This was the uh, uh, initial HRCT. So, coming to the end of the session, suggestions highlight the importance of SpO2 measurements at ICC and hospital settings to RHOs, MOs, and nurses and all the staff. Close observation during the window period with daily pulse oximetry, that is mandatory and the bare minimum. If somebody asks, do the post-exertional desaturation test before discharge. In the recent few days, there has been reports patients are dying after going home, but please make sure you do. This test is being used at very many developed centers in the developed countries as an exit criteria from the wards. You do the same test, and if the saturation doesn't drop below 96, patient is safe to be discharged. Early detection of the group who desaturate less than 94 to give triple therapy and triple measures to allow and I strongly recommend to follow the national guidelines, sticks to the national guidelines, wait till I can't say to wait till saturation drops below 94, but that's up to you all to decide, but certainly not do not give steroid for all. Group who does not desaturate below 94, at least to monitor closely and put them on triple measures. There is a non-pharmacology, at least close them very slowly. And if you do not allow them to exert themselves, their saturation will not drop further, meaning they will not go into increasing stages of ARDS. Safe use of oxygen, how to prevent rebreathing and conserve oxygen. We dealt a little bit on this regard. And safe transfer with oxygen. This is a must. Everybody need to be very conscious. My senior colleagues at BHH and even at IDH would agree that sometimes we get calls saying patients is stable on saturation 96 on with a face mask, but by the time patient reaches our OPD, saturation is 70 and patient is almost so adequate oxygen. Everybody should know how long can an oxygen cylinder last. With a 5 liter per minute oxygen, at least you need 300 liters per hour. A small cylinder will have 600, 700 max. A jumbo cylinder will have more. But what if the patient oxygen delivery rate increases up to 10 liters per minute? The saturation the cylinder will finish in half time. And most of the time, patients are getting desaturated. And make sure the observational appeal, make sure that patient has got enough oxygen during the delivery and proper appropriate rate according to the measures, and enough extra oxygen cylinders. And even with extra oxygen cylinders, make sure that there's somebody to change the oxygen as soon as the oxygen finishes at the back end of the ambulances, because cylinders, they cannot get connected automatically. Mix and this is what I meant by safe transfer. Always, from the smaller hospitals need to escalate the treatment and transfer the patient, and in the bigger hospitals, the beds needs to be kept ready for this kind of patients. That's how we can maintain the workflow. Make some 1 to 2 minute WhatsApp Viber type videos to junior doctors and nursing staff through colleges and ministry. Upgrade knowledge in a short span of time. Guidelines are better. It's a must, but always we need to put this 1 or 2 minute small descriptive things. MOs are quite useful, quite used to see this WhatsApp. Even I do not see anything more than 5 minutes. Anything, it takes more than 5 minutes. So implement MED protocol as an exit criteria for all discharges. In that way, we can prevent deaths at home after being discharged. So this whole thing is being practiced at district hospital Vatara and in base hospital Homagama, in the wards, on admission, clinical evaluation, fever, cough, shortness of breath, this usual stuff. And all the patients get, if the saturation is more than 96 and more than, if they do not show any contraindications, they get a exertional desaturation test plus they get daily exertional desaturation test if they are stable enough, and they get an exit test as well. So this same thing that we discussed up to now, we have had nearly quite a number of patients. We could observe, we could detect quite a number of patients. Out of these patients, 25 out of 84, 28 out of 135. Not all these patients needed escalation of treatment, but only 6 transfers and only 1 death after being transferred to a higher facility. And the patient that I showed you, the patient saturation was, when the patient was seated, it dropped to 84. At one end, patient is at the this district hospital, where the end patient saturation is 96 on oxygen. But when we are seeing the same patient from the other end, after being transferred, saturation can drop further because these patients cannot move, cannot transfer. I mean, even with the NRBMs and even with oxygen, their saturation drops. I don't know why, but it happens. It's quite scary. And few acknowledgements for all the patients who gave consent to record these videos. All throughout, I have hundreds of videos like this to use the videos and their data for educational and research purposes only. There are no hidden agendas or purposes on recording these videos, just to upgrade our knowledge. I'm sharing this with you for the sake of saving lives, if possible. Nothing new. These are the patients that we are seeing in our wards day to day. If you see, you will believe. Unfortunately, there is no time to do RCTs. Please do not share these sensitive videos and information on social media or public media. We all are professional body and professionals are all gathered here. It will only cause agitation. Surely it will jeopardize all our efforts. Special thanks to so many people to thank. All my colleagues, doctors and staff of BHH, DH Vatara and IDH and for giving me this, I mean, whenever I have because I didn't know anything about COVID 1 year back when I took over COVID unit Homagama, but I was fortunate enough to work with people like Dr. Narangoda. He was quite experienced, and always I had connections with Dr. Ananda Vijay Vikrama, Dr. Damayanti. Always, if I had a problem, they were go-to peoples for me. And I special thank to SLCIM, Professor Tilak Jayalat for escalating this, Professor Saroj Jayasinghe being the live wire behind pushing this forward, and Dr. Ananda Vijay Vikrama and other senior colleagues who always encourage me and giving me guidance. And special thanks to Bodhika Samarasekara, a respiratory physician who spent nearly 4 hours at District Hospital Vatara, seeing these patients, testing, checking, and their CTs and everything, and shouting out loud in one of his lectures. And Dr. Trishanta Jayasekar for sharing his views probably today. Gayan Ranasinghe sharing his experience with us today, if time permits. All consultants who gave me positive feedback and delivered this talk today. And list is too many to thank. Thank you. Sorry, I took too many times because, sir.
Yeah, thank you very much.
Sorry for the lengthy presentation, sir. Sorry.
No, that's fine. I think we all enjoyed it. I think it was a very comprehensive, very interesting, very practical presentation. And I think I have 2 highlights from your presentation. One is that we should get close to these patients and monitor them carefully, even at the early stage. I think that's something that we can take home as an important message. That's the way that we can detect hypoxia early. And the second highlight for me is that rather than looking for a wonder drug to treat COVID-19, I think it's more important to get our management steps right. I think which is what transformed the management of dengue. I mean, there is no specific drug for dengue, but identification of the critical period at the right time and management made a huge difference. So I think probably we will go down the same way with COVID-19 as well. We'll have to improve our management, refine our management. And I think your presentation will go a long way towards that. And as you mentioned, I think you mentioned two names. You said that Dr. Krishant Jayasekara and Dr. Gayan Ranasinghe would also, like to share the experiences with us. Can I invite Krishant to?
Yes, Satish.
Yeah. Yes,
Satish. I think I just want to congratulate Mahendra for that excellent talk. Actually, we had a chat about a week back, and I was fascinated from his when we started practicing that. Actually, can I share one of my experience where I used his experience and we actually for the benefit of the patients?
Yeah, sure.
Now we get now, for instance, we get about 40 admissions to Karapiti a day. Out of that, about 60% are level 1, whom we transfer back immediately to the local ICCs. But on the initial few weeks, we didn't do this desaturation test, and when the saturation is around 98, we send them. But then we had a couple of patients bounce back, saying that, and to see this, some of the ICCs have staircases. So when they climbed the staircases, they desaturated, and they got scared and they transferred back immediately. So now we practice. We do this modified test before we send them to ICC, and after that we have never got a patient bouncing back. And I think we are practicing that, and there are a lot of other things that also, because even when we transfer patient in between units, now these poor patients carry a bag and they walk from unit to unit, and we have noticed that they desaturate quite heavily. So this the physical effect of physical exertion and saturation has also been well proven, though it had been neglected. And I'm really thankful to Mahendra for highlighting that to this audience. So I think since the time, I will not go further, but I would like to congratulate for the college to organize, and then also Mahendra to actually highlighting the important thing. Thank you very much, Satish.
Yeah, thank you, Krishant. And is Gayan there? Dr. Gayan Ranasinghe from Karavanella Hospital. Gayan, are you there?
Yes.
Yeah, Gayan. Yeah, we would like to hear. Yeah. We would like to hear. Yeah, yes.
Yeah. So I'll see whether I can share some slides with you all.
Sure.
So actually, what has happened about a month back, I called Dr. Bodhika Samarasekara. He said he has just been to weather. So then I heard the story, full story. He has been there for hours and seen what has happened there in weather. So I also thought this is a good way of detecting this subclinical hypoxia, then contacted Mahendra as well. So within few days, because we have been getting more and more patients, that is after New Year season. So we saw a lot of patients come in with normal saturation on air. Then up to that point, we were not doing this regularly. So this patient, this is one of the best example. We call him Mr. X. He is a staff member from our ward itself. He just had sore throat 3 days. No fever, no cough, no shortness of breath. However, he was quite concerned about COVID and he got admitted. Then we examined him. There were no lung signs and all the hemodynamic parameters were normal. And he had no past medical history as well. In fact, he wanted to go to the nearest intermediate care center where he can rest and wait because his rapid test came positive for COVID-19. Then by that time, I knew this saturation test from Mahendra very much. So I said, okay, first we'll do this before sending you to ICC. His saturation was 96 on air and there were no contraindication for desaturation test. So I asked him to do this sit to stand 8 times. Then within 30 seconds, his saturation dropped to 92. Even at the saturation of 92, there was no shortness of breath, no complaints at all, fully asymptomatic. Then, with the consent of the patient, we have done the HRCT. Classification, mainly the lower zone, and the severity score was 7, not that bad. However, this is the first one we detected with the desaturation test, and he had pneumonia. If we have not done this, he would have ended up in ICC. We don't know what the progression would be, but as Mahendra highlighted, this subclinical category definitely we have to identify, because he clearly showed us this poor yield with the big resource setting will not be a winning game for us. So definitely, I think we have to identify this category. So if we all, that means I think so many participants are here. So I think we can do a bigger change here. If we take these practical points, I think we can do a lot for our patients, because resources are very much limited and the patients' numbers definitely going up day by day. So Mahendra has done a wonderful presentation. It's very informative and very practical, easy to teach our juniors. So I think we have to take it forward. Thank you very much, Mahendra, and I have to thank Dr. Bodhika Samasekara, because he's in weather and this thing is quite helpful. So thank you very much, everybody, and thank you very much for giving me this opportunity. Good night.
Yeah. Thank you, Van. Yeah, thank you very much. Yeah, I think I must mention here that at the moment there is a pilot project going on in the Kalutara district, where some patients who have been forced to be at home because of lack of facilities in hospitals are being monitored by a team of doctors, PHIs, and in their monitoring mechanism, exertional dyspnea is given prominence. And as Mahendra has used very correctly, the fact that, I mean, they are asked to sort of do something similar to the sit and stand test, and if they do report any difficulty breathing after that, they are asked to immediately inform the medical team, and they are taken out of home and placed at a level 2 hospital. So I think, and this probably is very important for us to manage, to detect hypoxia in the ICC setting, and to transfer these patients to at least a level 2 hospital. And also, as Krishanta correctly said, on the release of patients from tertiary care institutions to lower level hospitals, this can be used, this protocol can be used for as a exit criteria. Anyone who wants to ask questions from Mahendra or Gayan or Krishanta right now can raise their hand. I think we can have a few questions. Dr. Pudu Jayasekara has asked, does desaturation mean pneumonia in COVID without other symptoms and signs unless proven otherwise? Probably he wants to know whether patients who, if you auscultate, if you don't hear lung signs, could desaturation still be due to pneumonia? I think probably you have answered the question, but Mahendra, you want to address that?
So I didn't get the question.
Yeah, no, the question is,
yes.
Does desaturation mean pneumonia in COVID without other symptoms and signs?
Yes.
Like, so probably I think he means without lung signs, can there be pneumonia if there is exertional desaturation?
Yes, it is. So it is well proven that COVID pneumonia can be there with asymptomatic patients. There are so many case reports and so many writings on that. So and even with COVID pneumonia, there is a subclinical group where where sometimes, they may, when you say without signs, no signs of increased work of breathing, that we have to emphasize. Sometimes, they can have fevers, sore throat, anosmia, all sorts of things somewhere down before coming to before somewhere before. But uh, uniformly, what we have observed is that these patients who die or who are needing escalation of treatment, oxygen is the cornerstone of management at this point. Everybody needs oxygen where when they start uh, showing increased signs of work of breathing, it's going hand with low saturation levels. So less more than 96, still yes, you still can have pneumonia. That we say that patients with, you can divide that group into two: patients with normal saturation with early exertional desaturation, or patient without showing desaturation. So sometimes, in a pandemic situation, somebody asked whether if the PCR testing is you can't do, can you use saturation testing to detect COVID pneumonias? Yes, theoretically yes. And all what you want is to detect patients with desaturation and to get them admitted. So even in a pandemic situation, but when there's a test positive and saturation drops below 96, yes, you can have COVID pneumonia. And depending on the degree of the exertion, their saturation drop varies. Mild to moderate exertion, it may drop to 92. But if you ask the patient to climb 2 stairs or run or do some heavy manual work, it will drop further. Yeah, thank you, sir.
Yeah. There's another question, Mahendra. Do you use CRP and D-dimer in your management? If so, how do you modify your management based on that?
Yes, CRP, yes, it's a very, very, very useful asset when I'm practicing at base hospital, Homagama, but it is not there when I'm practicing at Vathara. But with the help of the staff, I was able to arrange the investigation from Homagama. So usually CRP is helpful. Sometimes, ERP, but sometimes, maybe CRP may be at 20s, 30s, or sometimes maybe around 100 to 200 levels. So it may be directly due to COVID or maybe due to sepsis. Not sure. But sometimes, according to the WHO guidelines and all, so if the pressure drops and signs of ARDS and sometimes this patient needs warrants antibiotics. CRP, yes, you can use that as a disease marker, and sometimes you can use as an antibiotic to give antibiotic guides, but I'm not pretty sure because it may be due to COVID, it may be due to maybe due to sepsis per se. But what we are practicing here is that we invariably at least give short course of antibiotics for this HU type desaturating group, and we see a drop of CRP. CRP is 120 to 180s, coming back to 0 to 20 on discharge. That is quite remarkable. So yes, it helps. And regarding the D-dimers, quite variation we have observed. If you can remember that 31-year-old lady, her D-dimer was more than 5,000. So according to the national guidelines, it's clearly mentioned there. If the D-dimers are more than 1,500, you may tend to give therapeutic dose. Yes, of course, depending on the dose adjustments according to the other diseases. And if the D-dimers are below 1,200 or so, if the other clinical things are not there, sometimes you may tend to give 30 to 40 milligram daily prophylactic dose. Therapeutic dose would be to give 40 BD or 1.1 to 1.5 kilogram per body weight daily or divided into two divided doses. But sometimes, patients with severe COVID pneumonias, we get very low D-dimer levels, and sometimes with very less symptomatic patients, we get very high D-dimer levels. So I'm not pretty sure how that correlate directly with disease severity. If you can remember that Nivea patient, his D-dimer was little low. Yeah, thank you, sir.
Can I answer question?
Yes, yes. Thank you, sir.
There are 2 points. One is that I think it's important to remember that radiological changes can be present in asymptomatic people who have who are asymptomatic. So, which means the test per se is of limited utility to diagnose the presence of a pneumonia. That's one, because I mean you can have it because you can anyway have it when you do the radiological investigations.
Yes.
The second issue is the importance of using this as a screening, which you highlighted, to send to higher levels of care rather than precise diagnosis. Because now when you say precise diagnosis, what I mean is someone can ask the question, could this be pulmonary emboli? And
Yes.
have you excluded it with D-dimers and CTPA?
Yes.
Now, physiologically, the fact that it is reversible may suggest that it's not pulmonary embolus, but then we are not using a gold standard. And overseas, some of our colleagues say that when they do CTPA, you find pulmonary emboli in people whom you never ever thought there would be pulmonary emboli. So I think the utility of this is the fact that it will pick up people who have to be shifted to a higher levels of care and further diagnosis, and will save lives.
Yes, agree, sir.
So I think that's at the end of the day, that's the important thing which we have to do. And my suggestion is that the college escalates this, discusses this in the expert committee, and escalates this quickly, because if this is useful, every day matters. There will be extra deaths if we miss. And you, all of you have highlighted how people just drop dead. And we have seen that drop dead phenomenon in Italy, and so many, I mean, you would have seen so many clips of people suddenly falling. Thank you very much, and congratulations once again.
Yeah, I totally agree with you, sir. Yes, yes. And thank you very much for.
Yeah, there was one other question, Mahendra. Now,
Yes.
there was a question asking you whether you recommend giving steroids to patients with exertional desaturation. Now we know, I mean, in the guidelines and in other guidelines as well around the world, 94 is taken as the cutoff point. And when the saturation is below 94, which is usually at rest, they describe, steroids are advocated. So do you recommend it for patients who desaturate on exertion also, or would you just monitor them and then start on steroids when the saturation drops down a bit more? Like what is your practice?
Yes, it's like this. Now, when you screen, maybe say when you screen 100 patients, sometimes this category, like it's exertional desaturation category, maybe it comes to around 20 patients, and out of that 20, maybe 3 to 5% will desaturate further. So when you think of the current practice, what we are doing at the general practitioner level and even at the base level, everybody is scared and everybody is searching for that magical prescription with steroids and all. Even with the day 1-2 fevers, it's very proven that that it can prolong the viremia and all. So there is a misuse of steroids in the community that we have to admit. So when you think of that lines, at least if you can, first thing is to get that 20%, separate that 20% out of that 100, And what we are practicing at the moment is that, and separate that. And then if their saturation drops further, we are, and if the patient, the time has lapsed, at least 5 to 7 days after the onset of clinical symptoms, and that sort of criteria are met. Yes, sometimes in case by case basis, according to this thing, might be useful, but I would rather want to stick to the guidelines as of now. But my main point is that saturation 94 doesn't mean on what ground is it always at rest. So if on a patient with saturation 94 at rest, it doesn't mean that their saturation is 94 when after climbing a flight of stairs. So if it drops to 88, as Dr. Trishanta said, and doesn't that patient warrant some form of treatment? But what we are advocating at the moment is that we want them at least to separate them out of the lot, and to put them on the triple measures. That is quite totally non-pharmacological. One thing, the prone positioning, awake cyclical prone positioning with alternate left and right lateral positions, and sometimes if during the exertion, if the saturation drops to 88 or 90 or 92, sometimes we ask them to get intermittent oxygen, right? So you ask the patient to put on oxygen for 5 minutes and then go to the toilet, come back, and another 10 to 15 minutes, put on some oxygen. So in that way, we are covering the exertional period. And third thing is to not allowing them to do extravagant things even within the ICUCs and all. Sometimes people tend to do all sorts of exercise programs, Sharirika Suwata, Vedasatahan, plus a lot of activities, sometimes music and dancing kind of things. So I think that is not necessary. We are not allowing the dengue patients to do that. Even at the height of the dengue epidemic we experienced, even with the wards were full, we asked them to bed rest as much as possible. So some sort of a strategy would be beneficial. So again, coming back to the question precisely, just on case by case basis. Sometimes if all the other things, sometimes if the saturation drops to 94 on exertion, we might observe them further. But if it drops after walking and all, because this measurement of saturation is totally depend on the timing of what you do. Now, say for example, you in a busy ward, like you ask the patient to come to the pulse oximeter and you check the saturation. So the first patient may be we may be checking the saturation soon after exertion. But usually what happens is that you call out loud first 10 patients to come up to the pulse oximeter. So while checking the pulse saturation of the first patient, all the other 10 patients are resting. And maybe first 2 patients we are maybe checking the exact exertional desaturation, but all the other patients who are seated in line, we may be checking the saturation low. So it doesn't. It is very, 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 very subjective thing, saturation measurement in a ICC setup or in a busy ward. So it is very operator dependent, and it depends on the degree of exertion, especially in this group. So there may be a place for severe desaturation on exertion group, and I have seen some benefit of none of them developed further, maybe due to steroids alone, or maybe we are putting them strictly on that triple measures. We are not allowing them to exert themselves to any degree. Yeah, thank you, sir.
Yeah. I think you made a very valid point. I think, the guideline says if the saturation is less than 94, that is at any point. So if the patient exerts and when he comes back, when you check the saturation, if it's less than 94, definitely that patient will need steroids. And also, I think one other important thing is people who desaturate on exercise, probably they are likely to become hypoxic at rest very soon. So, that must be because of progression of disease. So I think it's very important to pick those patients up and treat accordingly. I see two hands are raised. I can't see them.
I'm Nandana, Dr. Nandana Jayatila from Peradeniya,
Yes.
the emergency physician.
Yes, Nandana.
Mahendra, in my experience in Peradeniya, just to share the experience, some of the guys who is in 30s and 40s, and they come with usually the cough and unusual SOB. The question I ask usually, is this SOB, shortness of breath, is usual or unusual for them? Sometimes asthma people, they say, yeah, it is a bit unusual comparing with the previous episode. And so most of the time I tend to get the VAT or point of care PCR, about more than 70% they became positive.
Yes.
And that is my just experience. The question is...
You're quite true.
My question, Mahendra, what about the dexamethasone? Is it 6 milligram? Usually we get 6 milligram. Do you escalate the dose of dexamethasone in the patient who is having more severe diseases? Or are we going to stick only for the 6 milligram? Or can you just
Yes,
let me know in your experience?
So going back to the Homagama Base Hospital, and I'm seeing all these because it's a tertiary care level, so we see all the bad patients there. Sometimes, steroids again, giving steroid depends on the timing of the disease. And since we are lucky enough to have the CT findings, sometimes, initially dexamethasone as per the international guidelines or ministry guidelines, IV 6 milligram daily for 10 days. And what I usually do in my patients is that, if the desaturation persists after 10 days, sometimes, if they do not desaturate, if the saturation improves after that, we tend to stop or tail off DEXA. But if the patients desaturate further, sometimes, or for a longer period, sometimes, we tend to drag it for little few more days further. And if you are lucky enough to get a HRCT, and if the HRCT shows some organizing pneumonia pattern, sometimes we might change over to 1 milligram per 1 kg, like 30 to 50 milligram of prednisolone. But coming back to your question, Nandana, now there are guidelines to say that IV methylprednisolone 1 to 2 milligram per kg dose is helpful in severe ICU setup patients, and we have tried that in several patients and so many patients. Yes.
But I mean, the doses, yes, 6 milligram, can we go up to about 10 milligram or 12 milligram? Do you think that we can?
Actually, I have, all what I have done is that if it is not responding, 6 milligram is quite a high dose, but I know there are few researchers says that 10 to 12 milligrams can be given. But instead of that, what we practice is that, we change over to at least a short course of rescue course of methylprednisolone, maybe 1 to 2 milligram, 60 to 100, 450 max, to 1 or 2, 3 days, and then coming back to the organizing. Because by the time, if you when you do a HRCT, sometimes, these patients, they show these crazy paving patterns and all sorts of organizing pneumonia patterns. Sometimes, then we change. But short course of steroids, yes, but DEXA higher dose. But instead, what we have, I'm not, I think, competent enough to increase the DEXA dose because I haven't used more than 6 milligram. But certainly for that early desaturation group, Dr. Satish, instead of IV DEXA, sometimes we give 3 to 5 day small short course of the oral prednio DEXA. That really helps, maybe. So without going for IV DEXA.
Okay.
Yeah, that's right. I mean, even in the guidelines, it says that either oral or IV DEXA can be used. So at the moment, I mean, in most guidelines, 6 milligram daily is the dose that is used for 10 days. But of course, there are trials going on comparing looking for new evidence. There may be a subset of patients who may need higher doses, but we don't have the trial, data yet, and some trials have shown conflicting results. So I think, still the jury is out there. We may hear something different in the future, but for now, I think most guidelines recommend a 6 milligram dose. I think somebody else also raised the hand.
Mahendra, this is Namal. So it's a great talk. I mean, it's very exciting data and you presented. So I have a question regarding the female that you have shown that had higher D-dimer level. My question is, was she having any pre-existing condition like pre-diabetics or any other sort of pre-existing condition?
Not to our knowledge, I mean, she didn't complain of that, she had some fever or some constitutional symptoms, actually we took over that patient soon before, I mean, the new year. We had little patients in the wards. So we took over some normal looking patients, to West Hospital Homagama. So that's how we got that patient to our setup. Yeah. But yes, correctly. But that is again, that's what I said, Namal, that that some very bad patients we have seen very low level. I mean, relatively low levels of D-dimers, maybe 200, 600s, or maybe very normal levels. And some patients, that's I cannot exactly correlate the D-dimer levels with the disease severity. Maybe they may be having, some autoimmune condition or antiphospholipid disease syndromes or anything, unfortunately. But what I have observed is that after this 10 to 12 to 10 days of treatment, their D-dimer levels comes down.
Okay, so the reason why I'm saying that, Mahendra, so in some of our patient cohorts, we saw that those who are coming with diabetics or pre-diabetics, they had a higher D-dimer level. That's why I was curious. You guys have seen the same kind of like us?
Not that patient wasn't a diabetic at all. So sugars were normal, 31, and that's for sure. But yes, certainly, I have to. That's a good point. To look into to research on. Yeah, certainly I will. I'll keep an eye on. Thanks, Namal.
Great.
Yeah. Yeah, I think Mahendra made a very valid point. Probably the serial rise or fall of D-dimers is also important in the management. Anyone else who wants to ask a question right now? I think we have run quite behind the schedule. It has been a very informative, instructive discussion. And I think the SLCIM thought of doing this to get all clinicians, physicians, emergency physicians, intensivists, anesthetists who treat these COVID patients to have a frank dialogue about the issues that we encounter. And this will be the initial talk of a series of such talks. I think we would like to invite other colleagues as well to share their experiences. And I'm sure there may be lots of other questions, but I'm sure Mahendra will be contactable to answer those after the webinar as well. So I must now thank, on behalf of SLCIM, thank all the participants. I think there are about 250 or even more, and they stayed right throughout the presentation. And must thank all physicians, then consultants of other specialties. And we look forward to meeting you again on a webinar like this. And I must thank the GETS Pharma team for giving us the technical support. I would like to conclude the webinar now, and I wish you all a good evening. Thank you.